All right, we still have some people joining, but I guess we can start with introductions. Good morning, everybody. It is my great pleasure to introduce Tyler Sparks today. As many of you know, he has been our pediatric neurosurgery fellow for the past year. He came to us by way of Florida Atlantic University and Medical College of Georgia for medical school and residency, and has been doing general pediatric neurosurgery with us this year. So he will go on to do another 6 months of spine pediatric training because he just can't get enough. And it's been a tremendous pleasure to have him here. As you can see from his title slide, Tyler has a big personality, and in addition to seeking excellence in neurosurgical care, he also seeks to find fun in everything he does. And so it's been really fun for us to hear about his adventures this year and see how he's made the most of his time in the Southwest. And we will certainly miss you after this month, Tyler. So please share with us.
All right. Thank you, Dr. Bristol. Yes, good morning, everyone. Thank you for joining Grand Rounds. As Dr. Bristol mentioned, I'll be going to Philadelphia after this to Shriners to do more training for peds spine deformity and scoliosis. And then I'll be taking a job in Greenville, South Carolina, joining a pediatric neurosurgery practice, but also working with the spine team there at the Shriners in Greenville. So that's why I kind of wanted to give a talk today about neuromuscular scoliosis. And yep, I guess we'll get started. Hopefully I've got a chance to meet everyone in the chat. I can't see anyone and I can't see myself, but if we haven't met, please come say hi to me before I leave at the end of the month. So unfortunately, I have no disclosures yet. And so what is scoliosis? Scoliosis is defined as a Cobb angle of greater than 10 degrees, and the Cobb angle is measured from the most tilted vertebra above the apex of the curve to the most tilted vertebra below that apex. And so what are the types of pediatric scoliosis? And I say pediatric scoliosis because there's a whole set of adult degenerative scoliosis that we're not going to talk about because we're here for the kids. And as far as the pediatric scoliosis, there's idiopathic scoliosis, which is actually the most common type of scoliosis in kids and can occur at any age, but usually in adolescence. Congenital scoliosis is due to malformations of the vertebral bodies and starts when they're very young. And there's a whole host of syndromes that are associated with scoliosis. So those are all kind of grouped under a syndromic scoliosis category. And today we'll be talking about neuromuscular scoliosis, which occurs in patients with underlying nerve or muscle issues. So, like I just said, neuromuscular scoliosis due to neurologic or muscle pathology. And in this picture, we see a little girl with cerebral palsy who has a leftward sweeping curve, which is in contrast to usually idiopathic scoliosis. There's a right sweeping curve. She also has a pelvic tilt, which can cause imbalance and lead to pressure sores, and we'll touch on that a little bit later. And also, if you notice in this picture, there's a small scar here and this hyperdensity on the X-ray, which I believe is a backflip pump, which a lot of kids with cerebral palsy end up having. And we'll talk a little bit about that later as well. So just a quick introduction. Like I said, scoliosis is a very common finding among patients with neuromuscular diseases. It is often progressive and resistant to non-operative management. There's a variety of challenges with these patients. They have difficulty sitting, and they can also progress to having problems with cardiopulmonary function. And surgical management always requires a multidisciplinary approach, especially in the preoperative medical optimization of these patients. And the risks of surgery are generally higher in this patient population than in idiopathic scoliosis. And so when I started reading about neuromuscular scoliosis, there's really a lot to go into and a lot to talk about, especially for all the different teams involved. But I thought today it would just be best to go through some of the most common diagnoses associated with neuromuscular scoliosis and how each of those diseases are impacted by the scoliosis and management of those diseases. So this is just a small list of the most common diagnoses associated with neuromuscular scoliosis. And I'll talk about Duchenne muscular dystrophy, spinal muscular atrophy, cerebral palsy, and myelomeningocele. And as you can see here from the Scoliosis Research Society, all of these diseases, especially the ones I'm going to talk about today, have a very high incidence of scoliosis associated with them. And this myelodysplasia refers to spina bifida, specifically myelomeningocele, and not the myelodysplastic syndrome or blood cancer. So we'll start with Duchenne muscular dystrophy. It is an inherited X-linked recessive disorder isolated to the dystrophin gene, causing an absence in the protein dystrophin. It is actually the most common form of muscular dystrophy in childhood, and screening is suggested for any male not walking by 18 months or by 4 to 5 years, inability to keep up with peers, or increased difficulty climbing stairs. Other clinical findings include pseudohypertrophy of the calves, proximal muscle weakness, Achilles and iliotibial band contractures, and a positive Gower sign. And this picture illustrates that, where the patients usually start in this prone position. They form this triangle while they're trying to get up, and then they use their own thighs to stand. So Duchenne muscular dystrophy, when the kids get spinal deformity, it's a form of flaccid neuromuscular scoliosis, which is in contrast to some of the things we'll talk about later. And like I said before, it's scoliosis is there's a very high incidence in Duchenne muscular dystrophy. And the onset of the deformity occurs when the patients lose the ability to walk, usually between the ages of 10 to 14 years, and the risk of progression once the scoliosis has started is very high. And because it occurs once they lose the ability to walk, the incidence of early onset scoliosis is pretty rare. So given that the scoliosis usually develops once the patient becomes wheelchair bound, screening is not required while they're ambulatory, but once they're unable to walk, radiographic screening should occur every 6 months. So some of the medical considerations is that there is progressive worsening of pulmonary function as the curve progresses, and muscle weakness, contractures, and spinal deformity result in a restrictive disease pattern. And this progressive decline typically occurs, like we just said, in the second decade of life. And patients with DMD should also undergo preoperative cardiac evaluation, including an echo, because of the incidence of cardiomyopathy and conduction abnormalities. And of note, for surgery, these patients are also high risk for malignant hyperthermia. So in ambulators, bracing should not be used, and I will say I think that'll be a common theme as we go through each of these disorders, that bracing is usually not used for definitive treatment, but can kind of help early on, but we'll more into that. But in the case of Duchenne muscular dystrophy, evidence suggests that it's ineffective for the treatment of scoliosis and may decrease the ability to walk. And DMD has, or one of the mainstays of treatment in DMD is corticosteroids, because they have been found to stabilize muscle strength. But things that concern us, the chronic use of steroids can lead to, well, fractures of any bone, but specifically compression fractures of the spine, and can cause weight gain, behavioral problems, glucose intolerance, GI symptoms, skin changes, and cataracts. So the goals of the surgical management are to maintain sitting balance, mobility, and minimize the effects of scoliosis on pulmonary function. And of all the pediatric spine surgeries, DMD has demonstrated on average to have the highest mean blood loss. And this is because of dysfunction of vascular smooth muscle, and decreased platelet adhesion. So, to combat this, in the OR, we usually use antifibrinolytics, and most recently, most of the evidence has shown that tranexamic acid has been the best. So, those patients are usually given TXA before and during the surgery. And then we use this machine called a cell saver, which is connected to the suctions on the operative field. The blood and the suction, everything goes into this machine. There's some waste products that are discarded, and the red blood cells are washed, put into a bag that can be given to the patient at the end of the surgery to help decrease blood loss. As far as the long-term outcomes, studies have suggested that spinal fusion does benefit patients beyond pulmonary functions. And this study here, one of many, it was a questionnaire that evaluated function, self-image, cosmesis, pain, quality of life, and satisfaction. And the highest ratings were in cosmesis, quality of life, and satisfaction. And this is just one example of many of a patient with Duchenne muscular dystrophy and a very severe curve, and preoperative photo and postoperative photo showing good alignment. All right, so we'll move on to spinal muscular atrophy. This is one of the most common single gene neurodegenerative diseases. Sorry, it has an incidence of 1 in 6,000 to 1 in 10,000 in newborns, and 95% of cases are caused by deletion of the SMN1 gene, which stands for survival of motor neuron 1. And loss of this protein leads to degeneration of anterior horn cells, leading to progressive muscle weakness. It is diagnosed by molecular genetic testing and is classified into 3 different types based on the age of onset and number of SMN2 copies. So these guidelines, published in 2018, show that if you have 0 copies of this SMN1 gene, then you have a confirmed spinal muscular atrophy, and then the severity is based on how many copies you have of this SMN2 gene. So in spinal muscular atrophy, scoliosis, like we said, very high incidence, particularly in SMA types 1 and 2. And that scoliosis leads to spinal surgery about 80% of the time in those patients with SMA 1 and 2. And the patients with SMA type 3 end up getting surgery 40% of the time. And but it's kind of variable because it's really associated with the age of the time when they stop walking. And in these non-ambulators, more so the more severe types, they're classified into non-sitters and sitters. So the very severe type, the patients that aren't even able to sit, in order to be considered for surgery, they must have a stable respiratory and nutritional function. And recent drug therapy advances have led to increased overall survival and functional improvement. So I think more of these patients are being considered for surgery. Among the sitters, scoliosis less than 20 degrees is monitored every 6 months, and scoliosis greater than 20 degrees can be given an orthosis to support their trunk. However, like I said, it doesn't prevent the progression of deformity, and serial casting is not recommended. It's more so a temporizing measure. Okay, so the general indication is for kids with curves greater than 50 degrees, but other things that factor into the decision are worsening respiratory function, hyperkyphosis, trunk imbalance, and pelvic obliquity associated with rib impingement, and this thing called a parasol rib deformity, which these patients get, that results from weak intercostal muscles that are unable to oppose a stronger diaphragm and can lead to thoracic insufficiency syndrome. So it's very important to have pre-surgical medical optimization of these patients. They end up getting pulmonary function tests if they're able to cooperate, a chest X-ray and a sleep study, EKG, nutritional assessment. Dietitians are involved, and anesthesia is also involved because these patients can have mandibular contractures, limited neck mobility, and they actually also have altered action of muscle relaxants because of the disease. So I wanted to talk really quickly about a kind of different surgical option called growth-friendly surgical techniques. And in patients that are skeletally immature and are 8 to 10 years of age and younger, growth-friendly spinal instrumentation allows for continued spinal growth and lung development and can actually be the treatment of choice in these younger patients. So there's a couple different types of growth-friendly instrumentation. There's traditional growing rods. There's something called a vector, which it attaches to the ribs. And I think, latest thing to hit the market is these magnetically controlled growing rods, which are implanted, but then can be adjusted in the clinic with use of magnets. This one study did find that implantation of these magnetic rods represents a safe and efficient method to control spinal deformity in children with SMA, achieving sufficient stable curve correction as well as increased spinal strength. The complication rate was lower than those that have been described for vector and other growing rod instrumentation strategies. However, the definitive treatment is a spinal fusion surgery, and patients 10 years old or older can usually be treated with definitive instrumentation with or without extension to the pelvis, which we can see here. And this has shown maintenance of pulmonary function, better weight gain, better sitting tolerance, and reduced respiratory infection. And I just wanted to show here the pre-op pictures, and you can see this severe curve leading to ribs almost touching pelvis, and the postoperative photos showing, again, good alignment. Okay, so we'll move on to cerebral palsy. Cerebral palsy has an incidence of 2 per 1,000 live births, and this is the most common cause of physical disability in children. It represents a spectrum of disease severity from mild functional impairment and near normal ambulation to total body involvement with poor body control and wheelchair dependency. And this spectrum is demonstrated by the gross motor functional classification system, which I've shown here. And like I said, really ranges from nearly independent to requiring some assistance to being wheelchair or walker bound. And again, even on that spectrum, having some assistance to needing full assistance. And scoliosis is common in cerebral palsy, especially with increased disease severity. Like we just talked about, the GMFCS 4 or 5 is more likely involved. And again, typified by rapidly progressing curves with large magnitudes, even after skeletal maturity. So the curve can lead to impaired seating balance, decubitus ulcers, increased caregiver demands, decreased socialization, and pulmonary impairment. So as opposed to previous two disorders we just talked about, CP is a static encephalopathy, and it creates some unique issues relating to the influence of spasticity and dystonia and more optimistic expectations for lifespan of these patients. Multiple comorbidities in CP create risks of complications from surgery, with deep wound infection and pneumonia being the most common. And like I said before, this is because these patients tend to have poor nutritional status, can have epilepsy, UTI, respiratory infections, feeding disorders, and a relative immunodeficiency. And development of scoliosis in CP is thought to be due to muscle weakness, lack of coordination, and abnormal forces applied to the trunk associated with either hypertonia or hypotonia. And the associated asymmetry and ischial tuberosity pressures, coupled with the decreased hip flexion and increased internal hip rotation, can have a substantial impact on wheelchair sitting and quality of life. As the patient gets older, both pelvic obliquity and spine curvature become stiffer, with increasing impacts on seating and caregiving, as well as operative risk. And this picture shows a patient that underwent spine fusion, but important to note is a lot of these patients end up having other surgeries involving their hips, which you can see here. So, oh, my slide got a little messed up there. Anyways, to evaluate scoliosis in CP, it begins with the clinical assessment of curve flexibility. There's a couple different ways you can do this, but one is shown here, where the parent holds the child and the examiner kind of uses their hand to assess for the flexibility of the curvature. And this is important because flexible curves, as opposed to structural, in younger patients can be temporized by seating adjuncts, adjusting their wheelchair, or they can even be put in soft TLSO braces. Sitting or standing AP and lateral radiograph should be obtained, and the curve characteristic, pelvic balance, and remaining growth characteristics are documented. And just wanted to mention real quick here, it's important to know about the Risser scale because it tells you the skeletal maturity of the patient and gives you a little bit more information about how the curve will progress. And it's seen by looking at the triradiate cartilage along the iliac crest here and seeing the progression of that. And vertebral rotation that's seen in rib deformity suggests skirt curve is more structural than flexible. And an MRI is always warranted if there are suspicious symptoms, such as rapid curve progression, hyperlordosis, or change in neurostatus. And this is done to look for things such as tethered cord. So the treatment option in cerebral palsy, patients are typically medically fragile, increasing their risk profile. Initial close observation of curves less than 20 degrees is reasonable. Like we've said before, most say bracing is ineffective as a definitive treatment, but may slow progression. Stretching or Botox may be helpful, but does not manage the deformity. And serial casting can delay the surgery until the patient is at least 6 years old or curve has progressed greater than 60 degrees. But the definitive posterior spinal fusion from upper thoracic spine to the pelvis is usually the mainstay of treatment. And like we talked a little bit about before, there are growth-friendly constructs that allow for growth, but are really kind of controversial about which one to use, when to use it, the need for additional surgery, and that kind of thing. And here's some pictures of patients with CP showing a definitive fusion pre-op and post-op. And here's another picture of the growth rods being implanted. You can see is a lot less exposure of the spine. So that's why these surgeries are sometimes more favored. Here's x-ray of those growth rods after they're implanted, again showing good alignment. So the things to consider perioperatively with patients with CP, again, like most of the patients we're talking about, they're medically complex and pose significant risks, and their risks are directly related to the severity of their neurological impairment, which again goes back to the GMFCS score. Obviously, 5 has more risk than grade 4, and a lot of other issues that arise in kids with CP is the medical management of seizures, respiratory problems, nutrition deficiency, gastroesophageal reflux, and motility issues. Important thing to note is that these patients may be on a ketogenic diet for their seizures, so they're at risk for hypoglycemia. And if they're on antiepileptics such as valproic acid, this can increase the risk of perioperative blood loss. We talked about tranexamic acid before, and it's important to counsel the parents that obviously this surgery is very risky and there may be a prolonged ICU stay after surgery. Just a few quick things about the intraoperative considerations is that corrections of deformities can impede venous return to the heart, so need to be aware of that. And like I mentioned before, a lot of these patients end up having baclofen pumps, so the plans need to be made for that to either kind of try and go around the catheter and not cut it in coronary surgery, or an option is to pull the catheter out and replace it after the spinal hardware is placed. So a big problem, or I guess one of the main concerns of these big surgeries with lots of exposure of the spine is surgical site infections. And the risk of these surgical site infections is significantly elevated in children with neuromuscular scoliosis. There's been many guidelines published with a lot of different ways to try and control the infections. Some that they found have worked, some haven't. There's some new studies looking at dilute iodine irrigation and a negative pressure wound dressing applied after surgery. And I believe we have a small trial going on here looking at putting vancomycin powder in the bone graft that's applied along the spinal hardware. And yeah, anyways, a lot of different things to look at with preventing surgical site infections. So another very important thing in these patients is perioperative pain management, and it's been found that patients with neuromuscular scoliosis may be under medicated, and this is because intellectual disability or nonverbal patients may have difficulty communicating their discomfort, unlike verbal patients. There are a couple different scales to measure pain in patients. One that I found is called the FLAC score, which looks at face, legs, activity, cry, and consolability. Multimodal pain management is always indicated, and pain management service consultation is always recommended and can help a lot with these kids. So because these surgeries are very risky, a good look and a real pragmatic assessment of the benefits of surgery is required. And there's a couple different outcome measures, but one I'll talk about here is one called the Caregiver Priorities and Child Health Index of Life with Disabilities, or CP Child. Nice name. Questionnaire. It looks at a couple different factors: quality of life, comfort, interaction, positioning, transfer, and personal care. And the measurement of the health-related quality of life in patients with, it looks at the measure of the health-related quality of life in patients with CP and severe neurologic impairment, like we talked about before, the GMFCS 4 and 5. And they found that despite the risks of surgery, CP patients undergoing scoliosis surgery appeared to have a relatively long life expectancy and overall appears to improve their quality of life. All right. The last one we'll talk about is myelomeningocele, near and dear to my heart. This is actually a picture of a patient that we repaired about 2 weeks ago. And for those of you on here that haven't seen a myelomeningocele, quite striking. But you can see here in the middle, that's the spinal cord or the neural plateau that's obviously flat when it should be in a tube and surrounded by some malformed kind of arachnoid. There's dura underneath the sac, fascia, and the obvious thing is there's no posterior bony elements to the vertebra. And here's sort of a axial cut looking at the same thing. You see the spinal cord is flat instead of in a tube. The bony elements are usually splayed out to the side instead of normally being over the spine. And there's some combination of epidermis and dermis, and the nerve roots coming out in their normal orientation. And so what happens is that the neural folds do not close to form the neural tube, the ectoderm and mesenchyme do not migrate medially, and the neural placode is exposed. And paralysis paralysis is at the level of the exposed neural tissue and results in neuropathic bowel and bladder and multiple developmental orthopedic deformities. So the biggest thing to note is that the level of this spine defect differs, and it really makes a huge difference. Obviously, whether it's in the thoracic spine or lumbar spine, but even one level of difference of where this lesion is can mean the difference in a patient that can walk with braces versus a patient that's wheelchair bound. And so obviously the prevalence type and severity of all the deformities associated with different levels of myelomeningocele will differ. Again, another common theme. Scoliosis occurs in a lot of children with myelomeningocele and is usually present by 10 years old. Yeah, I guess some of the formatting of my slides got messed up when I emailed it. Anyways, curves may be congenital, developmental, or both. And paralysis is the main cause of developmental progression of the curvatures. And some predictive factors, like we said before, include the level of lesion and the motor function, their subsequent motor function, their ambulatory status, and the last intact laminar arch. And this is a patient with myelomeningocele. You'll note the shunt tubing coming down here. And this was at different ages of curve progression. And something you'll note here, this is called a unilateral bar. So in addition to the myelomeningocele, the development of this curve, he also, or she, I'm not sure, has a congenital cause of scoliosis, which is this failure of segmentation on one side of the vertebra, which sort of creates a fulcrum around which the curve forms. So I wanted to talk a little bit about tethered spinal cord. So essentially all children with myelomeningocele who have undergone operative closure have a low-lying spinal cord due to the repair. And so when we're repairing it, we try to close up the placode back into a neural tube, and then close the dura around that. But kind of no matter what you do, some tissue from the placode or the sutures used to close that up creates some scar tissue, and all of these patients end up having some type of tethering. And other than hydrocephalus and or shunt malfunction, tethered cord syndrome is the second most common cause of clinical decline in these patients. And a tethered cord release will improve or stabilize deteriorating motor or urologic function. However, a clear consensus for the indication of surgical untethering and the treatment of scoliosis has not been established. We know that the untethering will help symptomatic patients, but we don't know whether untethering will prevent prevent the need for a spinal fusion. And I'll touch more on this a little bit later. And the most important thing is to detether when the deformity can be attributed to tethered cord syndrome, and things that make you think it's attributed to the tethered cord syndrome are large deformities at a young age, a high rate of progression, and like we just talked about, any type of neurologic deterioration. Again, as far as braces and orthotic treatment, most widely accepted indication for bracing is to slow curvature progression and allow growth before definitive fusion, and again can improve function by providing support for seating. So as far as surgical indications and planning, surgery is commonly recommended for major coronal curves greater than 50 degrees, but this presumes that the deformity is symptomatic or will progress to become symptomatic. And most common scoliosis-related functional problem is seating, and imbalance. So surgery can fix this. And it also improves self-esteem, self-care abilities, and pulmonary function. Again, like we talked about with some of the other diseases. Another indication for surgery can be skin ulceration because of the pelvic obliquity and the way these kids sit in their chairs. However, I think as we know, skin ulceration is multifactorial, depends on a lot of factors, and surgery obviously does not guarantee resolution of the ulcers. So the curves are likely to progress, but surgery may cause some adverse health consequences. And some of those consequences are infection, pseudoarthrosis, which is kind of a fancy word for non-union, or failure of fusion of two vertebral bodies in the construct, leading to movement and problems with that down the road. There can be instrumentation failure of the rods or screws, and surgery sometimes can cause neurologic insult. So the big dilemma in surgery for, well, we're talking about myelomeningocele patients, but really neuromuscular scoliosis in general, is that surgery for less severe deformities is risky and may cause complications and may endanger some in whom the deformity may not become symptomatic or problematic per se. However, waiting to intervene until symptoms occur will lead to larger and more complex deformities and increased surgical risk. And not sure if any of our spine team is on here, but if there's any comments about this at the end, I would love to hear them. So again, these patients, as well as the other ones we talked about, require careful preoperative evaluation because myelomeningocele is a multi-system disease and involves all the teams seen here. And I just wanted to make sure I have time. Touch real quick on our perioperative considerations. So shunt function should always be evaluated because acute hydrocephalus may follow spinal cord manipulations and large shifts. So any kid with myelomeningocele shunt, always check the shunt first. And now we'll revisit the spinal cord tethering. And I do want to mention that this spinal cord tethering is different from something like fatty phylum or when I say like the congenital cause, things like a fatty phylum versus like we talked about the tether cord caused by the surgery and scar tissue. So this type of spinal cord tethering must be addressed, but prophylactic detethering, which is usually done to prevent neurologic injury during surgery with no symptoms of tethered spinal cord, is not indicated. And it kind of makes sense. So if you think the spinal cord is tethered and you do the correction of the spine and elongate the spine, you would think that would create extra tension on the spinal cord. So it kind of makes sense that a prophylactic untethering should be done, but there's been a couple of studies done looking at this, and specifically in these patients, again with myelomeningocele tethering, we're not talking about fatty phylum or other types of tethering. This study, it was done in 2010, suggested that spinal cord untethering may be unnecessary in patients with myelomeningocele who are undergoing scoliosis corrective surgery and do not present with clinical symptoms of a tethered cord, so asymptomatic patients, even though tethering is radiographically demonstrated, which we can see on an MRI. And another more recent study in 2019 showed that asymptomatic children with myelomeningocele who underwent scoliosis surgery developed no neurologic injuries regardless of prophylactic untethering. However, those that did undergo prophylactic untethering were more likely to experience surgical site infections, return to the OR, need for a blood transfusion, and increased length of stay compared to children not undergoing untethering. So they concluded that prophylactic untethering in asymptomatic myelomeningocele patients prior to scoliosis surgery does not provide any neurological benefit and is associated with increased surgical risk. So I thought that was kind of interesting. And again, if anyone has any comments on that, I'd love to hear it. And with that being said, okay, good, that's good time. I just want to say thank you to the spine team for letting me hang out with them in the OR. And thank you to everyone involved, all the teams in the monthly spine program meeting. Thank you for letting me be a part of that. And again, thank you to everyone at Phoenix Children's. It's been a great year. I've learned a lot. I did find out yesterday I passed my Peds neurosurgery board, so I did learn a few things. And yeah, thank you. It's been a great year. I did also learn yesterday that June is Scoliosis Awareness Month. And if anyone's interested, the Scoliosis Research Society at srs.org has a lot of great resources to learn more about scoliosis. These were two of the textbooks, really nice textbooks that I took a lot of things from. And I'll open it up to questions and comments.
Thank you, Tyler. That was a nice review. I don't know if I missed it, but could you comment on the age of surgical intervention in myelomeningocele? Like, for example, I saw a patient recently who's 9, and the family said that they know she needs surgery, but they want to let her torso get bigger before they have surgery. Is there data to support that, or where should we stand on that?
Yes. So this is the big dilemma. And I think it's very controversial, and there are lots of studies and lots of data looking at this. I guess the first decision is whether or not to intervene, and then the second decision is employing some of those growth-friendly strategies, like I talked about, the magnetic growing rods, traditional growing rods, Vector. There's a couple other like tethering procedures versus a definitive spinal fusion. So I think it really comes down to having discussion with them and talking about all the risk of surgery, and that performing the surgery earlier may cause some problems and have some risks, but can help them in the long run versus waiting until later. If the curve progresses, then it becomes an even more risky surgery. So I don't think there's any definitive answer to that question, but
Clear answer.
it's very controversial.
Do you think that does bracing work better in the spina bifida population than in the Duchenne population?
So I think that one of the main themes across all these diseases and all of neuromuscular scoliosis is that obviously bracing is not going to fix the deformity, but it may help, and it kind of goes back to your other question. I guess another option is bracing. It may help prolong the need for definitive fusion, in which case the surgery would be less risky. So yeah, I guess bracing is another option to, I guess, buy you some time. Oh, let's see. There are some questions in the chat. Oh, awesome talk. Thank you. How has gene therapy for Duchenne, muscular dystrophy, SMA impacted incidence and approach to scoliosis? Yeah, I mentioned that real quick. Gene therapy, along with other medical treatment for Duchenne's as well as SMA, I think in the aspect that it has increased their life expectancy, really brings something else to the table as far as talking about surgery, possibly earlier and possibly leading to, which I talked a little bit about, improved quality of life. So the more that those disorders can be treated on the medical side, I think the more options are open for surgery and improving their quality of life. Okay. Great talk. How has prenatal myelomeningocele repair impacted the scoliosis in the spina bifida population? Ooh, great question. So, yeah, there is prenatal myelo repair that's kind of recent, and it's gaining more traction in more centers across the country. There was the big MOMS trial that looked at a lot of factors associated with it and found that prenatal repair in general can lead to an increased level of motor function, which I talked about before has a huge impact on the level of function of the patient and progression of scoliosis. So they didn't look at this specifically. It may be a great study in the future of how it specifically affects scoliosis, but like I said, if it does add one level of motor function, maybe it decreases the need for scoliosis surgery or at least having earlier scoliosis surgery. But good question. Maybe a good study for the future.
Very nice. Thank you, Tyler.
Oh, yes. Well, yeah, there are a lot of other things with the MOMS trial, including decreased incidence of KR2 and need for hydrocephalus and need for
Boys just
a
rang
shunt.
our doorbell.
But don't think that has to do with scoliosis. All right. Yes. Thank you, everyone. I guess that's it, unless anyone has any other questions or comments.